Uh, on behalf of Muscat International Ophthalmology Conference, MIOC, and Ophthalmology Center, Armed Forces Hospital, I would like to welcome you all in Symposium 3. I'm very happy to introduce our speaker today, Dr. Isam Ruag. He's a consultant ophthalmologist and a vitreoretinal specialist in retina, head of retina services at Maghrabi Eye Center in Doha, Qatar. He's qualified from Tripoli University in Libya, and then he went for training in UK and become a fellow of Royal College of Ophthalmologists. He has done an advanced fellowship in VR surgery and medical retina, working in a high volume of retinal procedures in UK. He has a special interest in treatment of diabetic retinopathy and in application of artificial intelligence in common diseases in ophthalmology. He has delivered more than 40 presentations in various national and international conferences. So I welcome you, Dr. Isam, and over to you.
Good evening.
Thanks for giving us time in this your busy clinical practice.
Absolutely, it's a pleasure. Thank you very much for the invite. I'd like to thank Dr. Rasha Saidi and the organizing committee for inviting me to this conference. And thanks again for giving the opportunities. Today we will, when I thought about what we're going to do for this symposium, there was always a consensus about what do we do with anti-VEGF therapy when we compare results to real life with the clinical trials. And therefore, this is our talk will be today, is a different world of anti-VEGF therapy. So I'm just gonna share the slides with you now. A different world of anti-VEGF therapy. Different world was an American series actually in the late 80s, beginning 90s, where a group of students in university struggled to go through the college. Similarly, for retina specialists throughout the world, we do find it difficult to translate what has been provided with the clinical trials when it comes to applying these data to our daily practice. These are my disclosures. So when we talk about real world evidence compared to randomized clinical trials like Marina, Anchor, CAT, and Anchor studies for AMD, also other studies for diabetic macular edema, such as Vivid and Vista and Restore, and the other clinical trials for vein occlusions. It's always provided or indicated that not only patients gain visual acuity, but often significantly gain, despite severe damage and changes, these treatment regimens have proved that they continue to maintain their visual quality. But there's been a significant burden on the monthly treatment, and both is difficult to achieve routine clinical practice. This has led to people thinking about what could be the alternatives in terms of providing service to our patients without the burden of the number of injections and the visits that can happen. So when we talk about real world evidence, it's definitely the randomized controlled trials are the paramount and are the main when it comes to studying any medicine, any drug. However, the real world evidence does provide us with more knowledge and also give us better reflect of current treatment in the world. The randomized controlled trials have a higher internal validity, and this is because of these trials. They are very selective patients and the treatment protocols, and they ensure that all participants treated in the same way. When it comes to real world evidence, it's an observational. It's getting what's currently or what's been provided to patient. So it's an important complement to randomized controlled trials, and that's because randomized controlled trials does have limitations. It cannot show what happens in a broader population. So usually there's a small group of in the study group. It doesn't account for any environmental factors, and also it does not address the real usage of treatment. So, on the other hand, when it comes to patients for real-world evidence, it gives us that extra knowledge about the performance versus its potential, and reveal the differences of patient population. It gives understanding of the remaining unmet needs, outcomes, and safety. The real-world evidence comes from many places. It can be electronic health records, it can be claims and billing activities, product and disease registers, and patient-generated data, including home usage devices and settings, and data generated other sources. So it can be provided from so many routes and so many data available around us. But the scientific standards of evidence generated by this real-world evidence is more or less, and it's important in defining the outcome of any disease. So the growing needs for the acceptance of real-world evidence with the transition for healthcare system. So these days, healthcare system needed to know more about safety, about the performance of any treatment, including anti-VEGF. And lots of agencies like the FDA, the European Medicine Society Agency, they all request data safety and surveillances about the risks of these symptoms, these medications. And that's why real-world evidence does come to play when it comes to these questions. So just to put a quick comparison between real-world evidence and randomized controlled trials. In terms of purpose, we know that the clinical trials aims to assess the efficacy of any drug to be authorized to be used. On the other hand, the real-world evidence, it does assess the actual clinical practice. So these are the main differences. The research question is always about, does this drug work in the real world? Where in the clinical trials, it's about, does this drug work in experimental setting? Other factors, the follow-up, the study groups, and the comparators, as you can see, they all answer different settings, but the aim is to compare what has been shown in these clinical trials, those randomized trials, and when we compare them to real life. So I went through some real-world evidence of managing neovascular age-related macular degeneration with anti-VEGF therapy, mainly ranibizumab and aflibercept. And what we found is these three or four main observational studies: the flight retinal blindness project, and the value for evidence of real-world platform, and the Danish National Patient Registry, and finally the large US data about the visual acuity between ranibizumab and the treatment neovascular AMD. So if we go through the first study, the fight retinal blindness, Professor Mark Gillis from Australia, University of Sydney, he first presented or described the first project about collection of data for the outcome treatment for macular diseases. And what they found is a group in this study following these patients for 12 months, collecting the outcomes of treatment with ranibizumab and aflibercept, and they looked into visual acuity outcomes and the ocular disease adverse events. So the data they looked at is all from each clinic visits of patients, and they looked at the number of the letters they read in a logMAR, the visual chart assessment, corrective pinhole, and they looked at the choroidal neovascular membrane activities using different modalities, OCTs, angios, and clinical examination, but also looked at the treatment that was given, if any was given at that time, and ocular side adverse events that happened. The objective was to compare the visual acuity outcomes with ranibizumab compared to aflibercept for eyes with neovascular age-related macular degeneration, which treated in routine clinical practice. And the number of the treatment naive eyes were about 466. 72 of them was excluded due to exclusion criteria. So they looked at a total of 394 eyes for statistical analysis, which was divided equally between the ranibizumab treated eyes and the aflibercept treated eyes. And that was for a year, between they looked for all 12 months between December 13 and January 2015, with at least 12 months follow-up. The study design was based on analyzing treatment groups, which were three different groups. The completers, those who have received either ranibizumab or aflibercept treatment and completing 12 months follow-up. The switchers are any of those who had more than or equal to 2 injections of other treatment during or before completing the 12 months follow-up. And the non-completers are the eyes which didn't complete 12 months of follow-up as of 5th of May 2016. And the primary outcome was they looked at the change in visual acuity in each group over 12 months for initiating treatment. The secondary outcomes they looked at was what was the mean number of injections, the number of visits, the proportion of eyes in which coronary vascular membrane lesions was graded as inactive, and some points in the study, number of eye switching therapy and non-completers rates also. So if you look here, this graph, it's giving us the significant improvement in the mean visual acuity, which was observed over 12 months between the ranibizumab and aflibercept group. So the two of them, they performed and they improved in vision from 58.6 letters in the ranibizumab group to about 62.3. And there's a similar improvement also for the aflibercept group compared to ranibizumab. So they both proven to be effective in improving visual acuity over the first year of treatment. There wasn't any significant change in the injection frequency and the proportion of eyes with an active lesion between the two groups. If we look, there was an 8.1 in the ranibizumab compared to 9.6 number of injections. Also, the number of visits were almost comparable. And in the treatment group also, they looked at the active the patients with the coronary vascular membrane activity, which were deemed an active, which was about 74% and 77%. Number of injection, which is the main question whenever we comes to managing these patients. How many injections we're gonna give? And clinical trials has suggested that the magic number was 7. So the first year, 7 injections required. And then when they looked through these observational real world studies, data, they found that the number of injections also for those comparable 12 months between the two groups, there was no different. If you look at the proportion of eyes not completing 12 months of therapy, it was almost the same between the two groups. It's about 23% and 22.8% between the ranibizumab and aflibercept group. So in conclusion, from the photoretinal blindness study, there was significant improvement in visual acuity between the two groups, but there wasn't any difference in the injection frequency and the proportion of eyes with coronary vascular inactivation between the two groups, and the number of injection was comparable between the two groups throughout the 12 months period of treatment. And there was no significant differences in the proportion of eyes not completing 12 months, which is also interesting to notice in this study. The second study was the VERO study, which is the value of evidence in the real world platform. And what they did, they looked to compare the patterns of the ranibizumab aflibercept in managing neovascular AMD in the real world setting, also in 12 months period. And the question was looked at is what needed to be understood is how do physicians treat less frequent with aflibercept more than the ranibizumab for neovascular AMD? So if we look back into the clinical trials for VIEW 1 and 2 for aflibercept, the recommendation or the recommended label for the treatment is to give aflibercept three loading doses monthly, and then followed by a bi-monthly injection for the first year, which in contrast with the monthly injection of recommended in ranibizumab that was in the US. So the argument was in favor of aflibercept is the difference in the label dosing and the monitoring requirements. So we know that in the US, the ranibizumab is monthly injection, but outside the US, it's individualizing dosing and the monthly monitoring. But aflibercept is almost 8 weekly injection without monitoring. However, the analysis of these data suggests that physicians do not actually use ranibizumab and aflibercept differently. So the first results or the key objective was to compare the treatment frequency with ranibizumab and aflibercept over these first 12 months treatment using large US data. And the source was the user-integrated data warehouse, which is it's a large physician level claim database. And the population was the treatment-naive patients with the neovascular AMD, which is had 180 days without treatment prior to the index date. The integrated data warehouse is a claim database which encompasses approximately 1 billion professional fee claims per year. It's representing about 80% of practicing eye specialists in the US, including more than 13,000 ophthalmologists and covering all 50 states of the US. The short lag time for the entry of the database, remember that aflibercept was approved in November 2011. So that must be taken in consideration for these data available. So the patient who's starting with ranibizumab or aflibercept were followed in for 1 year. They looked at the patient who diagnosed with neovascular AMD, and the first claim for either of the injection was between November 2011, and and the 30th of November 2013. And they didn't have any treatment for at least 6 months before the index date. These are the treatment-naive patients. And they followed them for 12 months, and the number of treated eyes were 8,927, which showing the number of the ranibizumab group compared to aflibercept group. The patient characteristics showed that the majority, almost all patients above age of 70, and the prescribing physicians were almost all ophthalmologists. The female was the main group of gender for this study from the observation here. So what they found, there wasn't much difference in the mean number of injection if they were treated continuously, either with ranibizumab or aflibercept. So if you look at the graph, it's showing about 4.9 in the ranibizumab group compared to 5.2. So they were comparable, but these numbers of the injections in actual practice is lower than what the clinical trials has mentioned. So we know that from most of the clinical trials is recommending about 6.8, which is about 7 that we talked about, the magic number. So from this study, we can tell that we are undertreating the patients in that observational study. Loading doses appear to be administered similarly between the two groups. So about 66% of patients received the 3 loading doses between the two groups. And that's again is okay number, but we would aim normally to hit hard and give the loading dose as much as you can for neovascular AMD. The rate of switching also in the first 12 months was comparable with about 28% switched to other treatment in the ranibizumab group compared to 23% in the aflibercept group. Again, they looked at the number of visits, and that number of visits also didn't show any difference between the aflibercept compared to ranibizumab, despite the recommendation of the clinical trials for VU1 and 2 is a bi-monthly injection and also no monitoring. Patients still visited the clinics and had almost same number compared to the ranibizumab group. The mean number of visits that resulted in intravitreal injections in the first year also was comparable. So those who visited first year and had injection between the two groups, about 5.6 on average, with no different significance from aflibercept. And that's indicating similar treatment patterns despite the label differences, as we mentioned. The visits, the patients who visited but didn't get any treatment, again, you can see it's about 2.5 and 1.8 in aflibercept. So this is the number of patients who came. They either had the vision assessment, OCT, or fluorescein, but they did not receive any injection during those visits. Again, the visits, which are broadly similar to ranibizumab, despite perception that these should be much lower. So in conclusion, from this observational study, there was no difference in the mean total number of anti-VEGF injections when starting either aflibercept or ranibizumab, and the mean number of injections, if treated continuously, were also the same. And the loading doses appear to be administered similarly in the two groups, and the rate of switching was comparable between the ranibizumab and aflibercept. They had similar number of visits, so the clinic visits were a similar number, where you expect that the aflibercept should be less as per label recommendation. The number of treatment visits were broadly similar for the treatment, slightly more visits for ranibizumab. The world evidence showed that no difference in treatment patterns, and the mean number of visits again is no difference between the two treatments in conclusion. The third observation study was the Danish National Patient Registry, and this is one of the world's oldest nationwide hospital registers that's been used extensively for lots of researchers. And what they did, they had a look at the use of anti-VEGF therapy in Denmark, where they evaluated the injection frequency and treatment of the three most common retinal disease, the neovascular AMD, diabetic macular edema, and retinal vein occlusion. And what they did, they looked for first 12 months of treatment between January 2012 and 31st of July 2015. The study design was a non-intervention retrospective study, which obtained from secondary data in the Danish National Patient Register, and they went through about more than 1,200 patients were included in this group. However, about half of them did not receive the loading dose, so they have to be excluded from the analysis, the main analysis, but they continued for the ad hoc sensitivity analysis. So the final number were about 500 patients with neovascular AMD who received the loading phase initially. The diabetic macular edema group was 76 eyes, and the retinal vein occlusion was 82 eyes. So again, this is also compared to most of the observation studies in different parts of the world. It didn't show any evidence that the aflibercept were injected less frequently than ranibizumab in the real world practice. So if you look at the first two bars there, it's about 6.1 and 6.7 in the study group. So again, during the first year, we don't seem to see a difference in the number of the frequency of the injections that are being given. So if we look if we look into different groups, the different diseases, we would notice that the frequency of the injection for neovascular AMD was stable, whether or not they received the loading phase. So the number of the first half 2012 and the second half is about 5.4 mean standard deviation, and maintained almost the same all the way to the 2014 first half. So injection frequency for neovascular AMD was stable throughout the study period, unlike the other two groups, which we're going to come to next. If you look at the DME group, the number of the main injection frequency has increased throughout the study period. So if you look at the first half 2012 is about 5.14 mean standard deviation, 2.29. And increased all the way throughout the study period till the first half of 2013 is about 5.93. So it does increase, and the frequency of injections has increased in this observational study here. Similarly, for the retinal vein occlusion, they had also a number of injection increased from 2012 second half all the way to the first half 2014. Between 4.83 to about 6.08. To conclude the Danish National Registry, there was no evidence that aflibercept was actually injected less frequently compared to ranibizumab in the real world practice. And again, the injection frequency of all neovascular AMD patient was stable, whether or not they received the loading phase. So again, we said the one who didn't receive the loading phase was only for ad hoc sensitivity assessment. And the main injection frequency for DME and the RVO both increased, and the injection frequency for all of them indicated that has been different compared to real world clinical trial randomized control trials that has been provided to us. The final observational real world study is the large US outcomes of visual acuity comparing ranibizumab to aflibercept in a treatment of neovascular AMD. And this suggested that ranibizumab and aflibercept was not dosed according to wasn't dosed according to recommendation. We know that the pigment epithelial detachment is an important marker for disease severity and predictor for vision loss, and it's account about more than 60% in advanced neovascular AMD for these patients. So they looked into these groups of PED, pigment epithelial detachment, and they saw the response to both treatment, either aflibercept or ranibizumab. And what they found is they went through a total of 3,350 for ranibizumab and 4,300 for aflibercept, where they looked at the electronic medical records of patients in the United States, and they compared these two intravitreal injections for these patients. And the primary objective was to compare the mean change in visual acuity between index and month 12 and the treatment naive for neovascular AMD. So whether they are receiving ranibizumab or aflibercept to assess non-inferiority. They also looked at other objectives, which is the proportion of eyes gaining or losing more than 5 letters consecutively, up to 15 letters between the index and the month 12. And the mean number of injections also, they went through that, and they looked at them in the first 12 months. Follow-up period in the first 2 months after index injection and the loading period. So the inclusion criteria were those who have neovascular AMD with more than or equal to ranibizumab injection between July 11 and June 2014. And this first injection date was the index date. And then they excluded any patients who their eyes didn't receive the anti-VEGF within the first 6 months before the index dates were excluded. Also, discontinuation was defined as a gap of more than 180 days between study injection and the VA assessment during the follow-up. So the study population, as you can see, between the two arms, the ranibizumab and the aflibercept, and when they looked at those who had the pigment epithelial detachment, it was about 253 in the ranibizumab arm and about 203 in the aflibercept arm. And this is actually is a small number when we look at. It's about 6% of the study eyes. However, we know that PED is affect more than 60% in neovascular AMD, and this is because what they did, the coding for the pigment epithelial detachment was only for those who had the serous or hemorrhagic PED. So they didn't look at all pigment epithelial detachment types. They only went through the serous and hemorrhagic, which we know already it's about the 10% of the whole pigment epithelial detachment patients. The remaining, which is the fibrovascular and drusenoid, accounts for about 90% of pigment epithelial detachment. So this is the characteristic for the patients in terms of the treatment naive eyes. So interestingly, they were mainly those who had PED. They were above age of 85 and about 49%. So it's about equal between the two groups actually. The ranibizumab patients were slightly older than aflibercept, as you can see, and the female proportion was also higher in the ranibizumab group. So the visual acuity outcomes over 12 months, what they found is it's non-inferior to aflibercept compared to ranibizumab, the 3 months, 6 months, and also 12 months. and this means changes baseline was comparable between the two treatment. Again, the visual acuity for this subgroup, which is the pigment epithelial detachment group, also was non-inferior and was comparable. The subgroup, which is the subgroup for the BED, although I expect that they are the one who had this severity of the disease, and the response will be a little bit more difficult compared to the one who didn't have PED. But you can see that there's a great improvement in the two arms actually. So the visual acuity outcomes in all eyes according to baseline. Again,
as of all our patients, and
hello, sorry, I think there's a. Can you hear me?
Yes, yes.
Yes, okay. So the visual acuity outcomes in all eyes according to baseline, again, it was comparable and with a great improvement that has been achieved in patient which had more than with a visual acuity better than 69 letters or less than 69 letters in the subgroup. And this is what observational real world studies showing us, because in a clinical trial we tend to there was no clinical trial which looked at patients who had a visual acuity baseline better than 69 letters, usually worse than that. So we don't get much information about those patients. And clearly here we can tell that these patients had a greater improvement, and they maintained the visual function throughout the study period. So the proportion of eyes achieving predefined visual acuity was similar in the two of the groups, and that's for the letter gained and letter lost. If you can look on the graphs here, was not much difference between the two treatment. Again, here, if you look at the injection visits and the loading injection visits, there was no difference in the two groups. The chart number for the injection visit in the eye during 12 months across all subgroups. So there was the neovascular, there was the one who had the vision letters less than 69, and those were better than 69, and the BED group. All of them had the same loading injection visits, which is 1.8, and the injection visit following that also are comparable between the two groups. Again, this doesn't coincide with the label recommended the treatment for aflibercept. And this is the mean number of non-injection visits. So as you can see, it's about 2.15 in the two groups who didn't had the treatment while they were visiting during the 12-month period. So what we can say here, there's no clinically significant or relevant differences between the visual acuity at a 12 months outcome, although the label recommended dosing difference between the ranibizumab and aflibercept. And despite this dosing difference, comparable number of these two treatments were administered in patients, and the clinical relevance difference in visual acuity were negligible, basically. If you look at the real-world outcomes for this data, that showed about the average or mean dose of aflibercept is about 7, and that's, to be honest, it does coincide with what the VIEW 1 and 2 has recommended, is about 7.5. So it was not different from the clinical trials. In the ranibizumab group, this real-world data said about a 6.7 in the first 12 months, which was a little bit higher than what they previously mentioned in the real-world observational studies. But again, it's comparable to the clinical trials, which recommended about 7.7, or is a little bit less than that. So patients were injected a little bit less compared to the recommendation. Again, 6% of eyes in this study had pigment epithelial detachment, but we know why it's a small number, because they only looked at those who had serous and hemorrhagic type BED, where the majority of BED are the other types, which hasn't been coded when they looked at those patients during the study. So real-world data from this study suggests that the real practice show that there is a comparable evidence between the two study medicines, the aflibercept and ranibizumab, and in a wider binding capacity. It doesn't translate actually. So whether you have a medicine which has more binding capacity is like for aflibercept, which is the AAB and the placental growth factor also, didn't translate in real life for those patients in terms of visual acuity and the frequency of injections. The potential capacity of advantage for 8 weeks after the loading dose compared to monthly also didn't translate into real world clinical practice. So in conclusion, the visual acuity outcomes between the two groups, again, achieved similar outcomes in the first year. Again, the number of injection in this group, they looked at the aflibercept and ranibizumab, there were similar numbers of injections, and the efficacy maintained, vision was maintained in patients with high visual acuity, not normally assessed in phase 3 trials. So those patients who had vision better than 69 letters, they maintained their vision, and we never had any information about these patients in the clinical trials. So that this was an additional benefit of this real world evidence. So in summary, real world evidence is complementary to randomized controlled trials, that's for sure. But it's important because it has high external validity reflecting the real world practice. You get more understanding of the unmet needs, increase the knowledge about any treatment and its potential for treatment, and reveals differences in patient populations. We do agree that the RCT is the gold standard, but it does have some limitations in terms of an ability to show what happens in real population, and it doesn't consider environmental factors and it doesn't address the real usage of treatment. The Fight Retinal Blindness Professor Margill's group, they demonstrated that mean visual acuity had significantly improved in 12 months in the two groups, and the injection frequency was no difference between the two groups for treatment of neovascular AMD. Again, for visual analysis has proven that the total number of anti-VEGF, whether you're starting with aflibercept or ranibizumab, was comparable, and there wasn't any difference in the number of visits between these two patients. The Danish National Registry didn't show any evidence that aflibercept was injected less frequently as per label recommendation, and the overall injection frequency increased across all three indications. This large US data, which is has provided us with more information about even those with good visual acuity or better than 69 letters, achieved similar visual outcomes between the two groups, and similar numbers of injection in the first 12 months of treatment, and the therapy is effective even in those who had maintained high visual acuity, which is not normally assessed in clinical trials phase 3. This is a disclaimer for Novartis, and I would like to thank everyone for your patience and pairing with us. Thank you.
Thank you, Dr. Isam. Only I'll give small comment that we are one of the first center in Oman to use Lucentis. Yes, we launched actually most in the country, all country, and we have maybe the longest experience in Oman. I tell you the truth, still some patient after even they went to somewhere else and they use other type of injection, they come to us, they want same, and we feel this is still sustainable and useful for the patient. The most important, the follow-up, need follow-up. And many centers, I feel, because of the crowd, especially those public centers, because of the crowd, they miss something. They give the injection, but they don't check something else.
Absolutely.
Those, at the end of the day, those treatment, that's not easy. We are not giving only Panadol, like.
Yeah.
So we recommend our colleagues, doctors everywhere, to assess the patient before, after, and follow up and check his blood sugar also.
Yes, definitely. I think especially Dr. Rashid, for patients who have neovascular age-related macular degeneration, which is luckily we don't see them as common in this region compared to diabetic patients, diabetic macular edema or other retinal diseases. When you're faced with these patients, it's a paramount that you need to treat them on time, and you have to target a regular treatment, especially the first year. And as I said, we all know there is a magic number here, 7. So people trying to reduce the number of injections, I don't think they will compromise patient vision in this case. The loading dose with the number of injections following that for the first year is very important for those patients. Now there is a saturation mark for anti-VEGF, and usually if you inject even more than 7 during the first year, you don't tend to see the benefit, and that's why people tends to discuss the what would be the right number. But from clinical trials, from observation trials, those who had maintained their vision and they continued with less injections in the next year are the one who received an average of 7 injections of anti-VEGF. In terms of diabetic macular edema, again, I guess the recommendations provided in terms of giving 5 injections initially, and followed by whatever regime you want to follow, treat and extend or PRN. Again, I think this is what you get in terms of maintaining these patients' vision stability for these groups.
Great, thank you.
Thank you.
I don't see any question, but as I said, Lucentis is known already in the area since long times. What some reinforce the information for us, and he put all together. And instead of listening from Western world where they have different environment, different pathology, and as Dr. Sam said, the AMD not a big problem in here, but DME is a big problem, really big problem. But what we see from Lucentis is great result and saved a lot of patients from going to advanced stages. The only thing I advise all doctors and practicing doctors in the area to know that not like AMD, DMEs, they need to see other parameters. I need to talk to the patient about diabetic control, because at the end of the day, we are not benefiting unless the patient benefits.
Absolutely, and I still remember the discussion we had when I was in Muscat the last visit, and what you mentioned is great. That when you see a patient, you reinforce the HbA1c level when those patients come to you for any surgery, anything. And I think this is definitely a very important point to highlight. You can inject patients as much as you want, as long as the risk factors are still high in terms of HbA1c, blood pressure, other cofactors. You will never make that patient happy, and you will never be satisfied with the outcomes. So it is important to concentrate on not just treating the eye, but treating the patient as a whole. Is very important when it comes to diabetic patients.
Sure. Thank you very much. If there's no question, thank you very much, Dr. Isam, and thank you for giving us your time. And you are welcome anytime in Muscat soon. After, I think
it's a pleasure.
Soon will be over.
Thank you very much. It's my pleasure, and I'm looking forward to see you again and meet with you over there.
And
thank you, Dr. Rashid.
We thanks also Nufars that made COVID not a reason not to see each other. Now we saw you.
Absolutely. No, I'd like to thank the Novartis team for organizing this symposium, and thank you for everyone. Despite the short time, I think we made it happen. So thanks everyone.
Thank you. Bye bye.
Thank you. You have a good night.